Guys, welcome to the antihypertensive pharmacology lecture. Hypertension goals and guidelines change fairly regularly, but pretty consistently hypertension is defined as blood pressure over 140/90. Goals can be altered or decided to be stricter based on comorbidities and risk, and there's a lot of guidelines that will point that out specifically. It is the most common chronic disease in America, and therefore the medications that are used for it are some of the most commonly taken ones. And people generally will develop hypertension at some point in their life simply as the body ages. Some people obviously will develop it earlier in life due to different risk factors as well. If you think about hypertension, it's often called the silent killer. The reason is because having high blood pressure over time produces increased strain on end organs. So kidneys, eyes, brain, heart end up having strain over time, which can cause problems. And if you just look at blood pressure from a pure numerical perspective, 20/10 millimeters of mercury increases 2 times fold increased risk of cardiovascular disease. And of people who have hypertension, only about 31% actually have it under adequate control. So it's an area where there's a lot of people who aren't diagnosed and not treated properly, or simply are not able to be controlled with medications. So the big areas of blood pressure risk, we're talking about stroke, MI, and heart failure. Those are kind of the major ones. Kidney disease also has a component, of course, too. And eyesight can have a component as well. But if major studies have shown pretty consistently that if you keep blood pressure in goal, you get a 45% decrease in stroke, 25% decrease in myocardial infarction, and a 50% decrease in heart failure. So huge mortality benefits from just simply controlling blood pressure, which generally speaking isn't super complicated. There are patients that you'll struggle with in your careers if you do primary care or treat or cardiovascular care, but generally there's a lot of tools we have at our disposal to treat blood pressure. Most hypertension is essential. There's not really a single identifiable cause. There might be an age or obesity link, possibly increased salt intake and diet, but usually it's a combination of things that would lead somebody to have high blood pressure. There are some other causes considered secondary hypertension, things like primary aldosteronism, some renal disease, and other things I'm not going to go into. A lot more uncommon. First step, non-pharmacologic diet. Sodium intake has a direct role on fluid retention. So over time, if you're constantly consuming high amounts of salt, you're going to have increased fluid, which can increase your blood pressure. For most of us, if we eat a lot of salt, it doesn't really do much because probably just our kidneys are going to filter it out over time. So yeah, we might have a temporarily increased fluid or even a slightly hypertensive state going on, but our body's going to equilibrate that. It's over time when that becomes a problem that the body can't compensate for anymore, and ultimately it ends up slowly raising your blood pressure over time. Healthy body weight is associated with good blood pressure, so healthy diet and exercise, of course, as well. Caffeine intake, caffeine will certainly increase blood pressure, and the more regularly you consume caffeine, the likely you are to sustain those effects of having higher blood pressure due to caffeine intake. Stressful job, stressful events in life can certainly increase blood pressure. Smoking, moderate ethanol use, that's more of that ethanol use tends to increase blood pressure, so encouraging moderate ethanol use, I should say. Removing medications. There aren't a ton of medications that increase blood pressure. Probably the biggest ones that are common that are culprits are going to be NSAIDs. So again, drugs like ibuprofen or naproxen, those will have a decrease in the body's natural housekeeping prostaglandins and prostacyclins, which are natural vasodilators. So you don't get that effect from those particular compounds. Therefore, you have a more vasoconstrictive state. And if you take a single dose of one of these medications as needed, it's not a big deal. But if you take them every day chronically, that's where we can see transient increases in blood pressure. The goal for treating blood pressure is basically the same for everyone. The recommendation is to be less than 130 over 80. There's a lot of controversy about elderly patients, and do you give them a little bit of a break? And the guidelines would say that for elderly patients, you can ease up a little bit depending on how difficult it is to maintain blood pressure. It's just much more challenging to maintain a tighter blood pressure goal in elderly patients, statistically. And what if somebody's healthy? So let's say, everything checks out, you look great, exercise, you eat right, whatever, but your blood pressure is a little bit above that 130 over 80 break point. What do you do? Well, do you need to medicate a person at that point? Maybe, maybe not, depending on their risk factors. So those are some things that are a little bit gray areas within the guidelines. Okay, so this is where people, I think, get a little confused. So spend some time looking at the guidelines a little bit if you want to, but I'll try and break it down for you here. So if somebody has no cardiovascular disease and they have a 10-year ASCVD risk score, which is a atherosclerotic cardiovascular disease risk score. You can there's a lot of these calculators out there, but the cvriskcalculator.com is an easy one to use. There's smartphone apps and stuff like that too. But basically what this score is it's the percentage of risk of you having an event in the next 10 years. So if your risk is less than 10%, like in the first bullet point here, that means that you don't actually start medications until your blood pressure is over 139 over 89. So the guidelines would say that your ideal blood pressure should be below 130 over 80, but in between that and 140, which is kind of the threshold for actual hypertension, you don't actually have to treat. So that's one of the ways that they define that, giving kind of those quote unquote healthy people a break. If you have cardiovascular disease, a history of it, and your 10-year risk score is over 10%, you can start medications when blood pressure is over 129 over 79. Also, if you have any of the following conditions in addition to these or in place of these, diabetes, chronic kidney disease, or simply if you're age 65 or older. And again, that's a little controversial with targeting a more aggressive therapy for elderly patients, but there is actually decent data that by treating elderly patients more aggressively, you do get some benefits. So if you're over 75, so moving up in age group significantly, just 10-year risk score is going to calculate over 10% because a big component of it is age. And again, as we age, our risk for a cardiovascular event or a stroke or something like that goes up substantially. So those patients if you could be the healthiest 75-year-old on the planet, but your risk score is still going to calculate over 10%. You can play with the calculator if you want to put in numbers and see what it's like. But one of the controversies is that somebody, based on the guidelines, if they're over 75, is going to be on an antihypertensive. And do we need to put every person who's over 75 on an antihypertensive? Well, that's a good question. Especially if you're in kind of this middle area where your blood pressure is maybe not super elevated, but it's a little bit above. It's 135 or maybe almost getting close to 140. Do you medicate that person or not? And certainly, again, guidelines are guidelines. You don't have to follow them, but it's a recommendation by an expert body. So the idea is that they're giving you a framework to follow, and certainly there might be patients where it makes sense to prescribe it, and there might be some that don't. But just so you know, there's that little controversy with the age of patients there. This slide is something I took from Up to Date. It's considerations for individualizing antihypertensive therapy. So it goes through a number of different things and kind of tells you what drugs are preferred in those specific patient groups. So, for example, if you have a male who has benign prostatic hyperplasia or BPH, alpha blockers are a preferred drug, which is kind of one of the only ones where alpha blockers are actually used. If you have depression, a really old drug called reserpine is contraindicated because it can actually worsen or cause depression. So there's some interesting things here. We'll talk about some things called compelling indications, which was sort of a term coined by some guidelines a while ago. It's not really technically used anymore, but the idea is that based on certain indications the patient have, like maybe they have heart failure or diabetes or something like that, you would decide to treat them specifically because they have a certain set of diseases, and we know that those particular antihypertensive that are recommended for those patient groups have some additional benefits for patients with specific disease. So a good example is certain drugs like ACE inhibitors, which we'll talk about here in a minute, are kidney protective, generally speaking, if kidney disease hasn't progressed very long. So if you have diabetes, it's preferred to be on an ACE inhibitor because of that renal protective effect it has. So here you have kidney disease. I don't think diabetes is on here. Maybe I'm just missing it, but you get the point. So the question becomes, as if you have a patient who just has high blood pressure and nothing really else going on, or at least nothing within the cardiovascular realm or diabetes realm, no real other specific indications that would lead you to pick one therapy or another. So then the guidelines give you 4 classes of drugs, and these are the mainstays of hypertension management. So there's thiazide diuretics, what they call long-acting dihydropyridine calcium channel blockers, and then there's angiotensin-converting enzyme inhibitors, or ACE inhibitors, and angiotensin II receptor blockers, which are ARBs. The last 2 are kind of an interchangeable category. You don't use them together. It's one or the other, whereas these 2 and one of these. So you could be on 3 different drugs within this group. You could be on a thiazide, a calcium channel blocker, and an ACE or an ARB. You don't use ACEs and ARBs in combination. And the strategy is really just to mix and match within these groups. And once you have a patient on 3 drugs at optimal doses, if they aren't doing well with their blood pressure, you could add a different class on. But this is basically the core 3 therapies for antihypertensive management. And within each one, you really just have to be able to recognize the names of them and match them. Just like a lot of the things we talk about, there's not evidence to say that one is really better than the other. Generally speaking, when they study these, they might study one drug and then they pretty much will just apply that to everyone else. So we might say that, well, lisinopril is one of the most commonly used ACE inhibitor, but we haven't actually studied lisinopril that much. We studied captopril or enalapril or a different drug, but those drugs have to be taken more frequently. So it's kind of interesting where the studies will use a specific drug and then we end up not using that drug very often at all in real life. So you see that a lot. Okay, so those are the basics, kind of the building blocks of what we're going to talk about. Now we're going to dive deeper into the drugs. So first we'll start with the renin-angiotensin-aldosterone system. The 2 major drugs here are going to be drugs that work on angiotensin-converting enzyme, or ACE, and then drugs that block angiotensin receptors directly, which would be the ARBs. There is another class called renin inhibitors. There's only 1 drug in that category, and it's kind of odd the way it's used, but we'll talk about that here in a second. The point of this mechanism is to show you a bit how this process works. So angiotensin II itself is a vasoactive hormone that's produced in the kidneys, and it can cause vasoconstriction in different parts of the body, specifically in the cardiovascular system. It does some other things as well. But in periods of sustained stress, or whether it be actual physical, you're stressed out, you've got high blood pressure, or just because you've had high blood pressure for a long time and your body's kind of in a stress state, you'll tend to upregulate the production of angiotensin II as a way to compensate for this stress response, which is good in the short term, but chronically it can have negative effects on the body. So in this case, that's sort of the major target as far as what we're trying to block. So the drugs work 2 ways. Renin inhibitors work a different way, but let's focus on the main ones. So ACE inhibitors block the conversion of angiotensin I, which doesn't really do the same things. We don't really care as much about that one, to angiotensin II. And by doing that, you get a fairly significant reduction in blood pressure. Angiotensin blockers block the actual final receptor interacting with angiotensin II. So just by looking at this, you would think that you could technically use the two together because they're different, and you would, start, one would work upstream and one kind of works downstream. But studies have shown that they really don't do very well together. You don't really get any benefit by combining them, and you actually get increased risks of side effects, even some substantial ones. So we don't use them together, even though, from this diagram it looks like, yeah, that might make logical sense. It hasn't panned out clinically. The other thing I'll point out is ACE inhibitors also prevent the breakdown of bradykinin. So angiotensin converting enzyme not only converts angiotensin 1 to 2, but it breaks down bradykinin. Bradykinin is a sort of natural vasodilator, and by preventing the breakdown of this, you end up with more bradykinin circulating around, which is, again, going to give you some more vasodilatory effects throughout the cardiovascular system, which is a reason why people think ACE inhibitors might be superior to their ARB counterparts. Now, in most cases, they're interchangeable, but there is some nitpicking that goes on, especially when you treat a patient for heart failure. So that's one of the things to keep in the back of your mind about a big difference pharmacologically between the two, is that ACE inhibitors have a bit more of a broad spectrum approach, whereas ARBs are a little more specific in what they do. A lot of times in medicine, we're switching them out whenever we want to, but there is a difference between the two. And they aren't always studied the same way either, so we'll talk about that in a little bit. All right, so there's our 4 major classes of drugs. The first 2 are by far the big ones. Renin inhibitors, there's only 1 on the market. We'll talk about that. Aldosterone antagonists aren't really useful for blood pressure management. They're more used for heart failure and some other things, so we'll talk about that very briefly here and go back into aldosterone antagonists when we talk about heart failure in the next series of slides. Okay, ACE inhibitors all end in pril, so it's pretty easy to recognize what they are. They're first line for pretty much the majority of what we call compelling indications. So whether you have just regular blood pressure, or you have diabetes or heart failure, or you've had an MI in the past, you're pretty much always going to be on an ACE inhibitor. They're generally preferred across the board. So it's a good place to start for most patients, regardless of what other complications they have going on. They're relatively well-tolerated medications. I mean, you think like probably, I don't know how many tens of millions of people around the world take ACE inhibitors on a daily basis, but they're easily one of the most common medications prescribed in the world. Yeah, and relatively well tolerated. So your big side effects are going to be a cough. That's going to be the one that bothers people the most. And the reason why is because if we go back to the mechanism, the prevention of breakdown of bradykinin. If you do that, what happens is that can cause sort of a little mini, almost inflammatory effect in the lungs, and people tend to have this dry, non-productive cough, not associated with any type of illness, and that's a hallmark side effect of an ACE inhibitor. Angioedema is a really rare reaction that's almost like anaphylaxis. It's very similar, and we treat it basically the same way. And it's again really rare, less than 1%, but you can actually get it anytime you take an ACE inhibitor. So you could be on an ACE inhibitor for 5-10 years and then get angioedema. It's sort of an interesting reaction there. Renal dysfunction, we'll talk about this a little bit later. I can't remember if I have it in this slide or if we talk about it more I think we talk about it more during the kidney section coming up in a month or two here. But they can have some impact on kidneys, and I know you're probably thinking, well, you just said they're renally protective. They are in people who have healthy kidneys or people who have maybe very early stages of kidney disease. In later stages, it can be a problem, and it can be a problem when you combine it with other medications too. You might see some electrolyte disturbances, possibly increased potassium, usually not substantial enough for it to matter. It's just a transient increase. Same thing with serum creatinine elevation. Mild, transient. You don't see the an increase in creatinine so much where you'd say this patient's in kidney failure. It's just a small increase. Beneficial effects, we talked about that. Overall, again, these are first line for a reason. They're well tolerated. They're very effective. And these are examples of the medications. Lisinopril is by far the most commonly used one. It's once daily dosed. Every once in a while you see it BID. Its half-life is only 18 hours, so technically, like, if you wanted round-the-clock ACE inhibitor coverage, I've seen some people. I feel like there was a cardiovascular guy at our institution who got on a big BID lisinopril kick for a while, and then once he left, everyone kind of went back to once daily. I don't really see it used twice daily. I highly doubt there's any evidence that says it's more effective that way. But again, if you look at the pharmacokinetics, it technically does eliminate in 18 hours. So twice daily might give you more well-rounded coverage. The other drugs on here, captopril and enalapril, both are multi-dose a day, so you're usually looking at least 3 times a day for those medications. Ramipril and benazepril are less common. They're a little bit more expensive. And again, the point is there's no issue or there's no evidence that says any one of these is better than the other. So they're all pretty much interchangeable from a perspective of, you could try moving around within the class if maybe one didn't work and you wanted to try a different one. That's done sometimes, but for the most part, people are going to try lisinopril. If they get a cough, they're probably going to switch them to an ARB, and that's basically what you need to know about ACE inhibitors. The other 4 are very rarely used. And there are some other ones I didn't list on this slide, but you kind of get into the weeds on that. And again, if they end in pril, it's an ACE inhibitor, and they all do pretty much exactly the same thing. As far as other issues with ACE inhibitors, they are contraindicated in pregnancy. So for your pregnant patients or patients wanting to maybe start a family in the near future, that's something to consider. Renal function, especially if somebody is in acute kidney injury, like if they're dehydrated or whatever might be putting them into acute kidney injury, that's some place where you want to hold the ACE inhibitor. You could start it later, but just hold it during that acute time. And then the cough intolerance, which we talked about already. This just shows the mechanism of the kidney thing. So I guess I do have it in this set of slides. What happens is this is a nephron. So you have pressure in the glomerulus here that needs to be sustained to be able to filter things in the kidneys. And what happens is you have the afferent and efferent arterioles, right? And what happens is that ACE inhibitors actually prevent the constriction of the efferent side, and that can cause it to be a little bit less likely to have as much sustained pressure in here, just because you can't build up pressure as much if this is dilated. Now, if that's all you're doing, it's not usually a big deal. And in fact, again, this can be kidney protective because it can take some of the pressure off those kidney cells so that they don't die from sustained high blood pressure. And so that's a bonus effect. But if you do something like, for example, if you constricted this side too, then you really can't build pressure at all. So like if you take a medication like ibuprofen, it actually will prevent the prostacyclins from naturally vasodilating this side, and you end up with constriction on this side, which constriction plus dilation on this side ends up the opposite of what you want in a normal system, and that's where the kidney cells can actually become damaged at that point. And if you couple that with dehydration, with not enough fluid in the system too, you're compounding the issue substantially. So that's one of the problems with ACE inhibitors. It's a little bit theoretical as far as like you can take a dose of ibuprofen on an ACE inhibitor and not really have any issues. But if you're taking NSAIDs regularly, you're taking ACE inhibitors regularly, and then you go out and play a soccer game and get dehydrated, and that at that point you've got a possible serious situation that could hurt your kidneys. Angiotensin receptor blockers. These are usually considered to be interchangeable with ACEs from a therapy perspective. This is the medication people start if they have a cough on an ACE inhibitor. Bradykinin degrades normally, so you don't usually get the cough. Angioedema can still be seen. It has about a 10% cross-reactivity with ACE inhibitors. So in patients with ACE inhibitor angioedema, you do not use ARBs. That's too high of a cross-reactivity to make us comfortable, or to have us comfortable enough to use them. They might be slightly better in patients who have more severe kidney disease or diabetic nephropathy, but we don't really know that for sure. It's sort of a theoretical guess. Again, don't use these in combination. They end in sartan, and so there's a few of them on the market. Losartan and valsartan are probably the two most common ones. The other ones get relatively infrequent use, but occasional use. Losartan is also the least potent on the market, so you might see people start on losartan, increase in dose, and then they'll switch them to one of the other ones just to increase potency. Usually they'll just go to valsartan. If valsartan doesn't work very well, then that's probably enough. Aliskiren is a direct renin inhibitor, and so this is the only option available. Side effects are pretty similar. You don't use in combination. In fact, they've studied it in combination with the other classes and shown to cause significantly elevated potassium levels. The only time I've ever really seen this drug used is if somebody has pretty severe ACE inhibitor-induced angioedema. Occasionally they'll challenge people. So like if you're a heart failure patient or you're post-MI, the mortality benefits of being on a medication in this system are substantial enough where they might say, well, even though there's a cross-reactivity, let's try it anyway. But if patients are getting recurrent angioedema on different agents, this is a drug where they might try because it can be an alternative in that situation. So technically it's not recommended to do that, but it is probably this drug's only role would be in a patient meeting those criteria. Aldosterone antagonists, I'm going to kind of blow through these for now. We'll talk about them in a minute. The only real time these are used in blood pressure management is as potassium-sparing diuretics. So some of our diuretics that we use waste potassium, and these drugs will sometimes be combined with them as a potassium-sparing use. But generally, these aren't useful for hypertensive management. They won't lower blood pressure really at all. But we'll come back to these in a little bit. So I'm going to, again, skip them for now. All right, diuretics. There's a lot of diuretics out there, and we're going to talk about some of them in more detail today than others, but we'll come back to a few of them during the kidney lecture. Is a picture of your glomerulus and how things filter through and the different points where diuretics. So the green things are diuretics, and that's where they act on the different pumps and such within the glomerulus. All right, thiazide diuretics are part of our guideline recommendation first-line options. They are the historical mainstay of hypertension treatment and still pretty commonly used today. These were started out really high doses, and the doses have come down substantially. In fact, there's not a lot of evidence that anything beyond the starting dose of these medications does anything. You certainly get diminishing returns with adding more medication on. You can try it if you want to get more out of the therapy or you think the patient's responding well to it, but you might not get good increases in blood pressure beyond your initial dose. Good decreases in blood pressure, I should say, right? Inhibit their mechanism. So what they do is they inhibit sodium resorption in the distal tubule. They increase sodium and water excretion, increase potassium and hydrogen ion excretion, and retain calcium. So they can have some actual benefit for people who have osteoporosis or osteopenia. They do cause some secondary vasodilation via unknown mechanisms, so it's thought they might work beyond their effects in the kidneys, but we don't really know that for sure. Adverse effects, the biggest thing with any diuretic is frequent urination, and they also get less effective with diminishing creatinine clearance, so the more significant kidney disease you have, the less effective these drugs are going to be. There's also some association with thiazide diuretic use and increased risk of type 2 diabetes development, and we don't really know the mechanism, but there is a correlation there that's been seen. There's a famous study out called ALLHAT that came out several years ago. Thiazides were, again, the mainstay of hypertension. They were cheap, and all of a sudden, way back when, a bunch of drugs came out in the ACE inhibitor category and in the calcium channel blocker category, which is what amlodipine is. And they were more expensive. They were brand name products at the time, and this study basically said that thiazide diuretics are as effective as these new expensive therapies. So they've stayed in the guidelines for all this time, for decades, because they work, and we know how people respond to them. Probably my biggest gripe with these is this is going to be inconvenient for a lot of patients, but over time people might get used to how the diuretic affects them and how, significant this complication is. But that's probably the one drawback I see about this, is starting this on somebody. They just might be like, well, that's not convenient. Give me something else that doesn't do that. Doesn't cause me to urinate several more times a day than I'm used to. And that might be just a barrier to prescribing this particular class of drug. The only one to really be super knowledgeable about is hydrochlorothiazide. The other drug is chlorthalidone, which, interestingly enough, I think most studies out there, including AllHat, use chlorthalidone as the drug that they researched, whereas hydrochlorothiazide isn't actually as well studied. So it's, again, one of those situations, kind of like lisinopril, where that's the medication we use, but chlorthalidone is the one that was actually studied. Chlorthalidone is interesting because it's a much more potent medication than hydrochlorothiazide, and it's also much longer acting. So from that, you might think, well, maybe it's better at lowering blood pressure. But the flip side of that is these drugs are really notorious for wasting sodium on top of some other electrolytes, and chlorthalidone can significantly cause decreases in sodium. I've actually seen 2 cases of people, hyponatremia is to the point where people are severely hyponatremic is really quite rare. And I've seen 2 cases pretty much directly linked to chlorthalidone use or new chlorthalidone use. So it is something that can be seen with that drug, where you don't ever really see enough sodium wasting with hydrochlorothiazide to make it a significant deal. Metolazone is the third one in the class, and this one is, we'll come back to this during kidney disease, but this is only really used as needed for edema or if you need a bump of extra diuretic because you're retaining too much fluid and you want to basically force fluid through the kidneys. That's where this is used, but it's really potent. It's usually used in synergy with our loop diuretics, which we'll talk about here in a second, and that's really all you need to know. It's not a blood pressure management medication. So for blood pressure, you'll see people on hydrochlorothiazide 95% of the time. The other 5% you might see on chlorthalidone. Just be careful prescribing chlorthalidone. Make sure you're monitoring the patient relatively frequently during initiation of therapy. Loop diuretics aren't for blood pressure. They're for fluid accumulation and heart failure, and also used for chronic kidney disease to help the kidneys process liquid or remove extra liquid in a more efficient way. They're powerful diuretics. They work quickly and they don't have very long sustained effects. So basically you take an oral dose of this and it starts working within a few hours. You get a powerful diuresis effect and then it's out of your system. So it's really for short-term people take this daily, so I shouldn't say short-term, but it's more of a short-term burst of diuresis versus like hydrochlorothiazide is going to give you a more sustained, slow diuresis, which will help your blood pressures maintain over the day, whereas loop diuretics don't work like that. So anyway, we're going to discuss these more during heart failure and the renal lecture specifically too. We talked briefly about those aldosterone antagonists. There are a couple non-aldosterone drugs that also retain potassium, which can be important. So you see these different pumps have to do with potassium. So thiazide diuretics, again, primarily work on sodium, but they can also cause some potassium wasting. And potassium-sparing diuretics block a process that or helps a process that allows retention of potassium sort of at the very end of the collecting duct, and you get some of that potassium back that you've wasted out. So you'll see sometimes these drugs, triamterene and amiloride, prescribed in addition to drugs like hydrochlorothiazide. So in fact, hydrochlorothiazide is really commonly used in combination as a pill, so it comes in combination with amiloride or triamterene. We don't use them as monotherapy, but they are there as an add-on. Okay, calcium channel blockers. There are 2 major categories of these. There's the dihydropyridines, which is what's important for blood pressure management, and non-dihydropyridines, which are less potent vasodilators and work more centrally on the heart rate itself, which they have value as a rate controlling medication, but less useful for blood pressure management. So from a hypertension perspective, we're really just concerned about the dihydropyridines. And we'll come back to the non-dihydropyridine drugs in a little more detail and where we use those specifically. Calcium channel blockers, again, do a couple different things depending on where they work. Our just back to our dihydropyridine versus non-dihydropyridine differences. Dihydropyridine work peripherally for the most part, so they're working on calcium channels that are found in the arteries that cause blood pressure lowering effects. And calcium channels in the heart do a little bit different thing and are more responsible for heart rate and can lower those. Now, certainly if you lower heart rate, you can lower blood pressure in addition to that. But the point is that the focus isn't on lowering blood pressure. The focus is on lowering heart rate. You may get hypotensive effects because of that, but your bigger hypotensive effects are going to come from directly looking at working on blocking the calcium channels on the actual arteries themselves versus working with the heart. And then by doing that, you don't affect the heart rate negatively if you don't want to. So our drugs here end in dipine, dipine. Amlodipine is the one that's used most commonly. It's once a day. It's Norvasc is the brand name. It's been around for quite a while. And it doesn't really have any cardiac activity whatsoever. It's basically 100% peripheral acting. Some of these other ones get some use. Some use or a lot of use depending. Nifedipine is really popular in OB. There's actually some interesting studies that show that if you take nifedipine orally, it's almost as fast acting as if you give certain antihypertensive medications IV. Nicardipine is one that's I just mentioned because it is a calcium channel blocker, but it's used in IV form and it works really quickly. It's one of our mainstays for lowering blood pressure fast in emergent situations where somebody has extreme hypertension and we need to bring their blood pressure down really quickly. Nimodipine, I'm not going to test you on this. This is more for ICU care for people who have subarachnoid hemorrhages. It's really expensive. You have to dose it really frequently, but it prevents it prevents cerebral vasospasm, and so it can decrease the amount of bleeding and the amount of pressure in the cerebral vasculature. All right, side effects for dihydropyridines. Peripheral edema is probably the biggest one, so people will experience that specific side effect, probably more so than anything else. Headache and maybe some flushing as well, but generally pretty well-tolerated medications. We'll talk about heart failure, and this gets a little... I'm not going to mention this right now because we'll come back to this in detail, but generally speaking, people who have heart failure are going to be on so many medications that lower their blood pressure that they aren't going to need anything additionally. But every once in a while, you might need something more. But the point is that of this series of bullet points here is that generally with any calcium channel blocker and heart failure, we try to avoid them and we use them really cautiously. Amlodipine could be used if you needed additional antihypertensive effects. But again, once we talk about heart failure, hopefully you'll see why that would rarely be the case. Metabolic considerations, all three of these are really highly CYP3A4 metabolized. So amlodipine specifically, because it's so common, is one that can compete for that enzyme with other drugs. And so you might see increases in effectiveness of both medications if you give another medication that's highly CYP3A4 metabolized at the same time. Most are pregnancy category C, but again, nifedipine is a really common OB medication. So even though it's category C, not A or B, or we don't really have specific evidence per se. There's a lot of anecdotal evidence or case reports that say it's relatively safe to use in pregnancy, and therefore they all are relatively safe to use in pregnancy. The non-dihydropyridines, I'll just mention them quickly now since we're talking about calcium channel blockers. Diltiazem and verapamil. Diltiazems are kind of our go-to for rate control. We use it a lot IV if somebody comes in like atrial fibrillation, but it's a really powerful rate controller that doesn't really have a substantial effect on blood pressure. There are always the off patient that will get pretty substantial, a significant enough hypotensive response that will want to maybe dial it back a little bit, but for the most part, they just really control heart rate and don't do much else. Verapamil is a little more broad spectrum. It does have some more peripheral activity than diltiazem, so you do get the central acting chronotropic effects on it, so it does lower heart rate, but you also get some more hypotensive effects as well. So we don't use verapamil. Verapamil doesn't have a lot of utility. It's kind of a rarely used medication. I think of it maybe as like a further down blood pressure management line. Like if somebody's tried a number of other options, this could be one that you might try adding on. Or IV, it could be an alternative, but it's just not super common. In fact, it's used for other things like migraine prophylaxis, probably more commonly than it is used for cardiac indications. Side effects are mostly the same, with the exception of being absolutely contraindicated in heart failure and causing some more decreases in heart rate, so the bradycardia effect. Beta blockers end in OL or LOL. Drugs like propranolol is an example. These drugs really just are designed to decrease heart rate, and they have blood pressure effects at the same time. You notice this is the first drug we're talking about that wasn't part of the core recommendations for starting somebody on a antihypertensive medication. Beta blockers have a lot of historical use and were used first line, like even 10-15 years ago. It was really common to see a beta blocker first line for blood pressure, but it's fallen out of favor because mostly their side effect profile is just not great. Decreasing somebody's heart rate and preventing somebody's heart rate from increasing can cause things like exercise intolerance. It can make people feel tired. It can even cause mental health issues such as depression, or it can also cause impotence and even pulmonary issues, which we kind of talked about during the pulmonary lecture. So if you're blocking beta receptors and you're using a broad spectrum beta blocker, it can prevent the activity of drugs like albuterol from working. You can also mask diabetic symptoms. So sometimes diabetic patients, one of the things that they, as a diabetic patient, you're told to look for is to feel like if you feel your heart rate going up, that can be a sign of being hypoglycemic. And if you are on a beta blocker, you might not feel that symptom, or that symptom might be blunted. So you have to think about other ways to talk to a patient about how to identify symptoms of hypoglycemia, because that's probably the most easy one that people will feel or notice, that they feel like their heart rate's increasing. Usually people will notice that, but in this case it would be blocked and it wouldn't affect that patient that way. Here are all the beta blockers on the market. There's, again, quite a few of them. They generally have mostly the same activity with some varying degrees of differences. We're going to talk about heart failure in the next set of slides, but there are a couple that are heart failure approved. So for example, if you're going to treat somebody with heart failure, you only have 3 options. So carvedilol, metoprolol, long-acting only, and bisoprolol. The other ones can all kind of be used in various different forms. Atenolol is probably the most common one just for basic blood pressure use. It's once daily dosing, and it's relatively kind of mid-potency, so it's not going to affect somebody too much, as much as maybe some of these other drugs. Some of them are a little bit oddballs too, like sotalol is actually more of an antiarrhythmic medication, but it is technically a beta blocker too. Propranolol is a non-selective drug that's used a lot more for things like mental health indications than it is for blood pressure. So you've got things that are used sort of all over the place, but we'll talk about these a little bit more in detail when we come up to those specific ones. So I'm not going to go through anything more about beta blockers right now. We'll talk about beta blockers specifically during heart failure, and then we'll come back to them again during MI. So we'll get enough beta blockers that I promise you'll get this again, but just as an introduction here. All right, so managing hypertension. So let's just talk about this quick and kind of review what we just talked about. Concept of treating hypertension is you want to mix and match your classes, your compelling indications, so whatever the patient might be have in addition to hypertension would lead you to maybe pick a specific drug over another. Monotherapy is going to give you the biggest bang for your buck, so your patients are going to drop blood pressure about 30 to 50%. Of your patients will normalize just with one drug. So that's pretty promising. That's a decent number of hypertensive patients. If you can, you want to maximize the dose of a single agent the patient is taking before adding on a second agent. assuming they aren't getting any side effects and are getting good effects from the medication. You can consider starting 2 agents at once in a patient if their blood pressure is more than 20/10 above the goal. And the majority of patients, if we look at 30% to 50% respond to monotherapy, well, then the other half of people need more than that. So the majority of patients will probably require more than one agent, especially if you're significantly above your goal. Okay, so let's talk about some of the bigger indications here. Heart failure and blood pressure and high blood pressure can go hand in hand in a lot of patients. So why lower blood pressure in a heart failure patient? Well, hypertension imposes increased hemodynamic load on the failing heart ventricle. So reducing your afterload can have major improvements in stroke volume as well. So preload and afterload we'll talk about in respect to heart failure in a little bit here. But the point is that you can decrease the work the heart has to do, which can help it repair itself and prevents it from getting worse and ultimately failing completely. For heart failure patients, required therapies are ACE inhibitors, beta blockers, loop diuretics for fluids, and also aldosterone antagonists. And most of them will be on all 4 of these agents. And usually the dosing is restrictive based on how hypotensive and how bradycardic the patient gets. Most patients can't tolerate full doses of all this stuff. So adding anything more to control blood pressure specifically is going to be a moot point for heart failure because they're going to be on these medications. And again, we'll come back to this. We'll also come back to MI, but it's pretty similar to heart failure. You want to do ACE inhibitors or ARBs and a beta blocker. Those are the 2 big ones. Beyond that, other lowering strategies would be fine. So if you wanted to add a thiazide or a calcium channel blocker on, you could certainly do that as well if you needed additional. But again, most people are going to be on high doses of these. That's going to be enough to drop their blood pressure pretty substantially. Diabetes and blood pressure are really commonly seen together, and the 2 together compound and organ damage. So preventing that is, again, really key. So treating them both concurrently is usually done in therapy or in common medicine. So ACE inhibitors, ARBs, both protect against kidney damage. Thiazide, diuretics, calcium channel blockers, and beta blockers could all be used. This is sort of the order you'd pick, though. Stroke or transischemic attack, generally people are going to be treated with an antihypertensive whether they have significant hypertension or not. However, if your blood pressure is pretty low already, like below 120/70, you probably aren't going to do anything with it. There's a couple different guidelines too that have recommended things over the years, but basically people are saying that now 1 drug is probably fine, starting with an ACE inhibitor or calcium channel blocker, or using combination of the 2. Basically, it's nothing different than what we're doing already, right? We've already talked about all these options being first line, so for stroke, it's not really all that big of a difference. Some other therapies. So if everything else is maxed out, or you want to try something different, or you have some different indications, you might try something. So alpha blockers would be a drug that are limited in use generally due to orthostatic effects. They're prazosin or doxazosin are the common ones here. Again, they cause quite a bit of orthostatic hypotension, which is why they aren't first line, but they do work to lower blood pressure. So again, for older men with BPH, they could be a good choice to start somebody on because they'll help with prostate symptoms and with urinary retention from that. They'll also work for lowering blood pressure at the same time. Clonidine is a centrally acting alpha-2 agonist. It comes orally and also as a transdermal patch. So it's kind of an interesting delivery mechanism. Clonidine's got one of the fastest onsets when taken orally. And the nice thing about clonidine is a lot of people don't take it generally. It's not as common of a chronic medication. So if you have somebody in, this is sort of my pearl of wisdom, that if you have somebody in like an urgent care or ER or even a clinic and they're having hypertension and they're already on a number of other medications, give them a dose of clonidine, see if it lowers their blood pressure. It might just be enough to kind of push them over the hump and get them into a normal range. And it doesn't work the same way as any other class, so you have an option that's sort of unique with clonidine. and you don't have to give them an IV dose or anything like that. Clonidine has a fairly substantial amount of side effects: bradycardia, drowsiness, fatigue. Similar to beta blockers is what you're going to see here, but they do work a little differently than a beta blocker. Oh, I should probably mention this. Centrally acting alpha-2 agonist sounds a little weird. You might think that was a typo. It's not. So it actually works specifically to agonize alpha receptors in the central nervous system. That causes a specific pattern of vagal nerve suppression activity. So you get less things like norepinephrine output, and that's, again, working really upstream within the brain to prevent the sympathetic nervous system response basically throughout the body. So it's kind of an interesting medication. Hydralazine is a direct arterial vasodilator. It comes IV PO, fast acting. It's dosed several times a day. It causes a lot of flushing, chest pain potentially. Not extremely common, but it does come IV in PO, so you could use it as a fast acting IV or a fast acting PO option. Both work relatively quickly. Methyl-dopa was pulled from the market. I don't know if it'll ever come back, so I don't really want you to know this one. But this was, for a long time, always thought of as the mainstay for hypertension in pregnancy. It's sort of like a weak version of clonidine that doesn't really work all that well. So I think the couple companies that made it just got rid of it, and so we don't really see it anymore. So anyway, I don't want you to know anything about that one until it comes back on the market. It's not worth talking about. Beta blockers in pregnancy. Labetalol is a preferred drug. It's one of the more commonly used ones in pregnancy. Calcium channel blockers, they aren't well studied, but nifedipine gets used all the time, so it's thought to be safe. And hydralazine is the other one. So really, if you take out methyl-dopa, your three drugs are labetalol, nifedipine, and hydralazine. Other beta blockers and dihydropyridine calcium channel blockers are likely fine, but again, not as commonly used and not as well studied. And that's the last slide of this lecture. We'll talk about heart failure for the next series.